Hello, good morning. Today we are going to discuss Unit 6, that is somatic symptom and related disorders. And before that, we had already discussed about the schizophrenia, psychotic disorders, mood disorders, and anxiety disorders. So this is also a very common type of disorder which is highly prevalent in our society. So let us see what is somatic symptom disorder and other disorders. So what we are going to discuss today, we'll just describe about the symptoms, then we'll discuss about the somatic symptom disorder, illness anxiety disorder, conversion disorder, psychological factors affecting medical conditions, factitious disorder, and distinguishing between conversion disorder, factitious disorder, and malingering. So this is very interesting topic, and you must all learn this thing. So there are some, you might have seen the study material. So I'll be discussing one by one in all each topics. So many individuals keep running to doctors even though there is nothing wrong with them. Doctors say there is no problem, you are all right. But they used to visit the doctor with the multiple somatic complaints. So soma means body, and the common problem associated with somatic disorders and related symptoms seems to be initially physical disorders. So like the way patient describes the symptoms, it gives the impression that the patient is having certain problems. For example, migraine or brain tumor, heart cardiac problem, or something wrong in the stomach, abdomen. But even though with the repetitive investigations, there is usually no identifiable physical cause for the condition. So when the doctors do physical examination as well as radiological and other blood examination, there is nothing wrong. Doctor won't find anything problematic which can explain the basis of the disorder. So DSM-5 lists 5 basic somatic symptoms and related disorders. One is somatic symptom disorder, illness anxiety disorders, psychological factors affecting other medical conditions, conversion disorder, factitious disorder. In each, the individual has an excessive and maladaptive preoccupation with the functioning of his or her body. So the core characteristic of these disorders is excessive preoccupation with the functioning of the body. Like there is some problem in the body. So these are the 5 categories we are going to discuss. Let us see first somatic symptom disorder. So it is characterized by one or more somatic symptoms. Somatic symptoms means symptoms related to the body. However, there is no basis in the body. Physical symptoms such as pain are real even though the clinicians are unable to diagnose any physical factor responsible for causing the disease. So remember this thing. The patient say if he or she is having pain, it doesn't mean patient is not feeling pain. Patient is having pain. The pain is real for the patient. However, there is no reason for that pain, no physical basis for that pain. So there is a new emphasis in DSM-5 on the psychological and behavioral factors such as anxiety, distress, and time or energy devoted to the symptoms that seem to be aggravating the severity and impairment associated with the symptoms. So during the time of diagnosis, clinicians have to specify if the somatic complaints predominantly involve pain. So pain is the core characteristics of somatic symptoms disorder. Let us see the diagnosis. So 3 requirements for fulfilling the diagnostic criteria. First one is somatic symptoms that cause significant distress or disruption in daily living. So if there is no much distress or there is no disruption of daily living, then it may not be considered as somatic symptom disorder. One or more thoughts, feelings, or behavior that are related to the somatic symptoms which are persistent, excessive, associated with a high level of anxiety, and results in devotion of excessive time and energy. Symptoms lasting for more than 6 months. So these are 3 core characteristics of the somatic symptom disorder. Let us see the DSM-5 criteria for somatic symptom disorder. A. One or more somatic symptoms that are distressing or result in significant disruption of daily life. B. Excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns, as manifested by at least one of the following. So, disproportionate and persistent thoughts about the seriousness of one symptoms. So, even though the pain and the doctors say that it is not a problem, it is not physical, there is no need to worry, but the patient thinks okay, this is serious one, and persistently high level of anxiety about health or symptoms. Just tolerating pain, patient have lots of anxiety. Why the pain is there? Why the doctors are not able to find out? Excessive time and energy to these symptoms or health concerns. So, although anyone somatic symptom may not be continuously present, so it's not necessary that the symptoms may be different. Sometimes one symptom, sometimes other symptoms. So, how to treat somatic symptom disorder? So, like the primary objective is to help the patient cope with physical symptoms, including health anxiety and maladaptive behavior, as opposed to eliminating the symptoms. Then, regular visits must be scheduled to reinforce that the symptoms are not suggestive of a life-threatening or disabling medical condition, and the diagnostic procedures and invasive surgical treatments are not recommended. So, sedative medications, including benzodiazepines and narcotic analgesics, are avoided because the pain is not due to physical cause. So, painkillers may not be very useful. Early psychiatric treatment is recommended. Cognitive behavior therapy is associated with significant improvement in patient reported functioning and somatic symptoms, a decrease in health care cost, and a reduction in depressive symptoms. So, if we give CBT, there will be lots of improvement in this patient. And medicines are limited, but sometimes antidepressant, anti-anxiety, they work with some patients. Coming to the next disorder, illness anxiety disorder. So, physical symptoms are either not experienced at the present time or are very mild. So, physical symptoms may be there, may not be there. Even though they are there, they are mild. Accompanying anxiety focused on the possibility of developing a serious disease or different illnesses is excessive. So, the person may have believed that he may develop or she may develop a serious disease, and the physical symptoms experienced are mild, that we have already discussed. In case the physical symptoms are severe and are associated with anxiety and distress, the diagnosis would be somatic symptom disorder. So, this is the difference between somatic symptom disorder and illness anxiety disorder. Let us see the clinical picture of illness anxiety disorder. So, people with illness anxiety disorder show preoccupation with normal body functions. So, they often presented with minor physical problems or with vague and ambiguous physical sensations. The mental orientation of the individual keeps them constantly on alert for new symptoms, and they show notable preoccupation with their symptoms. So, an inability to give a precise description, yet detailed description of their symptoms to help the doctor find a diagnosis, even though there is no real illness. And some keep a detailed chart of their bowel movement, diet, constipation, and related matters. So, these functions are normal, like bowel movements, urination, diet, sometimes constipation. So all these are normal, but they are preoccupied with this normal functioning of the. There is something wrong with this functioning. This disease conviction is a common feature of both somatic symptom disorder and illness anxiety disorder. So there is a commonality between somatic symptom disorder and illness anxiety disorder is the disease conviction. Like they have firm belief about the disease. They are having one or another type of illness. The doctor-patient relationship is marked by hostility and conflict, since they generally resist the idea that their problem is psychological than physical. So this is the, I think, those physicians who are not very much aware about the psychological problems or psychiatric disorders. So they try to convince the patient that this is just psychological, nothing else. So like psychological means patient can control. So this is myth. Even though the problem is psychological, the patient cannot control those things. It's more or less like physical problems, but the basis is not physical. That is the only difference. So no need to argue with the such patients. So let us see the DSM-5 criteria. So first one, A is preoccupation with fear of having or acquiring a serious illness, and B is somatic symptoms are not present, or if present are only mild in intensity. If another medical condition is present, then there is a high risk for developing a medical condition. For example, a strong medical history is present. The preoccupation is clearly excessive or disproportionate, and there is a high level of anxiety about health, and the individual is easily get preoccupied with the symptoms. So the criteria D is the individual performs excessive health-related behaviors. For example, repeatedly checks his or her body for signs of illness or exhibits maladaptive avoidance. For example, avoids doctor's appointment and hospitals. So E is illness preoccupation has been present for at least 6 months, but the specific illness that is feared may change over that period of time. So the fear anxiety may be persisting for a longer period of time. The illness-related preoccupation is not better explained by another mental disorder, such as somatic symptom disorder, generalized anxiety disorder, or obsessive compulsive disorder. So before diagnosing illness anxiety disorder, you have to differentiate it with the OCD, somatic symptom disorder, or GAD. So there are two types of illness anxiety disorder. Care seeking type, like they always try to contact the medical persons. So medical care including physician visits, undergoing tests, and procedure is frequently used to care. Care avoidance type is basically they do not visit the doctor, they avoid visiting doctors, but they complain. So let us see the prevalence. So this illness anxiety disorder is about 0.1% of the general population. In our India, 0.1% is not a small amount, considering the 140 crores of the population. The disorder is spread fairly across various phases of the adulthood. Anxiety and mood disorders are often comorbid with illness anxiety disorder, and somatic symptom disorder tend to be chronic. Then the culture-specific disorders prevalent in India, like Dhat syndrome, which is excessive concern about loss of semen, fits with somatic symptom disorder, not in illness anxiety disorder. And Dhat is associated with a vague mix of physical symptoms, including dizziness, weakness, and fatigue. Such culture-bound syndromes are episodic, dramatic, and discrete pattern of behavioral reactions. So they are not present with this. Let us see what are the causes of this disorder. So basically, it is a disorder of cognition, perception with emotional contribution. Cognition means they are always getting thoughts related to their normal body movements and interpreting them as a abnormal. And perception, they perceive everything differently, and they are very much preoccupied or concerned about anxiety or depression associated with their symptoms. So individuals' past experience with illness leads to the development of a set of dysfunctional assumptions about the disease. This may predispose a pattern to developing uh, illness anxiety disorder. Like if the person has gone under surgery, so after surgery, the person may develop illness anxiety disorder. These assumptions are faulty, unduly alarming, and pessimistic. And misinterpretations of the bodily sensation play a causal role in most of the illness anxiety disorders. There is a strong history of family pathology. So, somatic symptoms disorders run in family and may have a modest genetic component. Okay, hyperresponsivity to stress is generally there may combine with the tendency to view negative life events as unpredictable. Like anytime, any negative life event may occur, so they are preoccupied with that also. Individuals tend to have disproportionate incidence of disease or diseases in their family. So, like learning from the family, usually triggered in the presence of a stressful life event or a death or an illness in the family or with them. Let us see the cognitive theory of illness anxiety disorders. So one is attentional bias, means the person is totally preoccupied with the bodily symptoms or interpreting those symptoms. So that is called attentional bias. Though the person can see lots of other things, can pay attention on others, but his attention is focused on excessive bodily symptoms. So they are likely to have biased attention for any illness-related information, event, or images, and they are hypervigilant about one's own bodily sensation. So second one is activation of faulty assumption. So illness related information activates the dysfunctional faulty assumptions. For example, as I told, after the some surgical intervention, a patient has gone for surgery or something. So after surgery, the person may develop illness anxiety disorder because lots of information he may gather which is not true. All these are based on faulty assumptions. Misperception. So individual may also misperceive their symptoms as more dangerous than they really are. Okay, those symptoms are not so dangerous, but the person may perceive them as dangerous. They see themselves weak and unable to tolerate physical efforts or exercise. So that's why they stop doing exercise and they don't do any physical activities. So physiological changes, increased focus on one's body can create arousal and makes the physical sensations seem more intense than they actually are. So if you pay more attention on your physical symptoms, you will be feeling them more. So there might be changes in bowel pattern, sleeping and eating habits. Like if you remain anxious, so the effect of anxiety will be on your bowel control, bowel movement. So behavioral responses engage in repeated behaviors such as checking, self-examination, taking preventive medications, reading about the illness. So they do lots of self-medication, not only allopathic medication, Ayurvedic, Unani, homeopathic, lots of all they try, they experiment with all sort of medications. So let us see this model in illness anxiety disorder. So there will be dysfunctional illness belief. So this is cognitive model. So hurt is equivalent to harm. So intolerance of uncertainty, overestimating the likelihood and severity of having an illness. So all these may lead to selective attention to threat. Then the person may become more body vigilant. Then it may lead to increased likelihood of noticing benign sensations. This may lead to perception of bodily symptoms, so misinterpretation of ambiguous symptoms. That may lead to catastrophic cognitions about illness. I may get certain difficult illness or uncurable illness or terminal illness. So this catastrophic cognitions about illness activates illness fear. that is anxiety and uncertainty, and that lead to motivation to prevent harm and attain certainty. So then the person may seek safety behaviors, and these safety behaviors basically prevents acquisition of disconfirmatory evidences and tolerance of uncertainty that may again lead to dysfunctional illness beliefs. So this is the cycle, and this explains very well about the illness identity disorder. So what is the treatment? Reassurance and education, that is psychoeducation by mental health professionals or psychologists. Don't say ki you don't have anything. Say yes, you are having problem, but there are two types of problem. One is physical, another one is psychological. So for physical illnesses, there are physical basis. For psychological illness, there are psychological basis. So if there is a psychological illness, it cannot be understood on the basis of CT scan or MRI or blood tests. Okay, it can be understood on the basis of test for mind, or test for behavior, test for cognition, test for personality. So accept that yes, this is illness. You are not faking. Psychology illness doesn't mean the person is faking the symptoms. So CBT helps these individuals by focusing on identifying and challenging illness-related misinterpretations of physical sensations and on showing them how to create symptoms by focusing attention on certain body areas. It tends to create awareness about the nature of the disease and its physical symptoms associated with it. It helps to understand that their symptoms were under their control. So don't get panic. All symptoms are under control. So psychoeducation work like help. Psychoeducation helps the individual to seek fewer reassurance and discourage individuals from relating to significant others on the basis of their physical symptoms alone. So if family members or doctors will give reassurance again and again, so the patient's belief may get strengthened. So no need to give reassurance again and again. Coming to conversion disorders. So let us see what is conversion disorders. Sigmund Freud popularized the term conversion. Anxiety resulting from unconscious conflict was converted into physical symptoms. So Freud has explained everything on the basis of unfulfilled desires which are stored in unconscious, and basically it tries to fulfill all the things. So whenever these desires try to come into subconscious, so ego get threatened. So ego, due to this tension, ego convert them into some physical symptoms, so we may say. In detail, that conversion disorder is given to subtitle functional neurological symptom disorder. Symptoms that result in absence of an organic cause. Some kind of neurological disease is affecting the sensory motor systems, but no organic or physical malfunctioning is present. So even though the symptoms seems like neurological, but there is no basis, no neurological basis. So this is the Freudian understanding about the conversion disorder. Unconscious conflict leads to anxiety, that leads to conversion of physical symptoms. So symptoms of deficits affecting sensory and voluntary motor functions. Differential diagnosis must to demarcate between symptom and recognize neurological condition. It prevents misdiagnosis of a genuine neurological or medical conditions. So there could be several sensory deficits. So there could be several motor symptoms like conversion paralysis. The patient may not move the right side of the body, upper limbs or lower limbs. There might be tremors, tics, contractures like hand movements like this. Aphasia is a condition in which individual has lost disorganized walk or both legs wobbling about in every direction, speech-related conversion disorders, so aphonia or selective mutism may be there. The person may not speak anything, or some patient may just whisper. Other symptoms include seizures or pseudo seizures. Seizures basically if there is a seizure, it has basis of some brain dysfunction. For example, EEG changes might be there, or some other problem in the brain. And in seizures, there will be loss of consciousness. Whereas in pseudo seizures, there won't be involvement of brain, and it is psychological in nature. Though the patient is not aware about the seizure, but the loss of consciousness may not be there in pseudo seizure. So there are certain things which can be differentiated between seizures and pseudo seizures. For example, in seizures, there will be loss of consciousness, there will be tongue bite, there may be uh, incontinence, and the person may hurt themselves. Whereas in pseudo seizure, there may not be tongue bite. Generally, tongue bite may not be there. The person may not hurt himself or herself. The person may be aware about the surrounding but not responsive, not responding. The person may not respond unless you give severe pain or severe something. And there will be no history of incontinence. So, a wide range of visceral symptoms, including lump in throat, choking sensation, coughing spells, difficulty in breathing, nausea, vomiting, malaria, tuberculosis, or pseudo pregnancy called pseudocyesis. There is no pregnancy, but the person believes that she is pregnant. Let us see the DSM-5 criteria. One or more symptoms of altered voluntary, motor, or sensory function. Clinical findings provide evidence of incompatibility between the symptoms and recognized neurological or medical condition. The symptoms or deficit is not better explained by another medical or mental disorder. The symptoms or deficits causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. It's basically like not be seen on any physical investigations or tests. Specific symptoms like with weakness or paralysis, with abnormal movement, with swelling symptoms, with speech symptoms, with attacks or seizures. So seizures means here pseudo seizures, not seizures. With anesthesia or sensory loss, with special sensory symptoms, with mixed symptoms. So you can specify the acute episode and persistent episode. In acute episode, symptoms present for less than 6 months, whereas persistent episode, the symptoms persistent for more than 6 months. So you can specify if with psychological stressors or without psychological stressors. So prevalence, the lifetime prevalence is not known with certainty. Highest estimates is around 0.005%. So not very commonly present, but in our country, before 10-20 years, it was highly prevalent. So women outnumber the diagnosis of conversion symptoms by a ratio of 2:1 to 10:1. People from low socioeconomic strata are more likely to develop conversion disorders. Less educated, poor, and staying in slums, so they show more symptoms. Conversion symptoms may appear at any time, but most people experience their first symptoms during adolescence or early adulthood. Onset is abrupt and typically follows a major stressor. The course of the disorder may either be episodic or chronic, and comorbid anxiety and mood disorder are also very common, seen in conversion disorders. So twin study does not support any genetic causes. So basically this is psychoanalytic theory explain this illness very correctly. And there are socio-cultural perspectives. So they also the symptoms are manifested on the basis of socio-cultural. So Freud has given a classical case of NAO. You all might be knowing it. So four basic processes in the development of conversion disorders, according to psychoanalytic theory. The person experiences an unconscious conflict. Since the conflict is unacceptable, the conflict and the resulting anxiety are repressed. So the person, everything is going in unconscious. The person is not aware. So then anxiety continues to increase and threatens to become conscious. The person uses the defense mechanism to convert the conflict into physical symptoms to reduce anxiety. And the person receives increased attention and sympathy from loved ones and may also evade certain undesirable tasks. So, for example, paralysis of leg were very common in soldiers earlier time to avoid the traumatic combat situations during the World War period without being labeled as coward or the person is weak. So let us see how Freud has or psychoanalytic theory explains the conversion disorders as we have just discussed. So unconscious, yes, then a repression, the conflict and resulting anxiety is unacceptable, thus repressed, and conversion of symptoms. So there might be some primary gain. Anxiety continues to increase and threatens to emerge into consciousness. So the person converts. So secondary gain, increased attention, sympathy, avoidance of difficult situation or task. So it has been seen that there is a history of a traumatic event, for example, sexual abuse in childhood or adolescent or later age, then recent parental divorce and death, and physical abuse. And in some of the states in our country has seen that this economic condition, that is like poverty and too much loan, is also one of the causative factor. So if we see the socio-cultural perspective, so over the past century, there has been an apparent decrease in the incidence of conversion disorders. The diagnosis of conversion has declined in Western societies, hardly reported there. However, in our country, it's still there. Rates of conversion symptoms are higher in rural regions where medical knowledge is sparse. So, if there is a more medical knowledge, more information, people are having money, people are having education, so the conversion symptoms may be less in such societies, such cultures. But in where the society is guided by the supernatural beliefs, they have lots of misconceptions, myth. They don't have adequate knowledge about the body or the symptoms. So there is a high possibility that they may develop conversion disorders. So that's why in our country still conversion disorders are prevalent. How to treat? So people with conversion disorders respond well to the cognitive behavior therapy. Identification of the traumatic or the stressful life event is the first task in the line of treatment. So, and the patient may not share very easily those stressful life events because they are in subconscious. So it takes lots of time. You have to establish rapport. You have to show empathy. Then only you will able to get those information. Therapist must educate the family regarding the role of secondary reinforcements such as attention and sympathy. But just saying the family member that no need to give attention and sympathy won't help. Rather may create more problem. So you have to prepare patient and the family member for that. So let us see the psychological factors which are affecting medical conditions. So now we are going to discuss about the medical conditions which are more affected by psychological factors, or the problem will be more when the psychological factors associated with medical conditions. Till now we have seen psychological disorders which do not have medical conditions. Now, patient is already diagnosed with medical condition, for example, diabetes mellitus, cancer, cardiac problems, and then psychological factors, how psychological factors affecting these medical conditions. So, already the patient has diagnosis of medical conditions. This medical condition is adversely affected by one or more psychological or behavioral factors. Psychological or behavioral factors have a direct influence on the diagnosed medical conditions, either by triggering or worsening it. For example, if the person is diagnosed with cancer, lymphoma, for example, which is curable, and but the person thinks, he's gone now, his cancer, so everything is gone now. What is the point of in living? So he should die. So there is no point of taking medicine. So all these things may worse the situations. So these psychological factors basically interfere with the treatment. So because the patient is not motivated to treat the illness, so the patient may not take proper treatment, the medication, and the compliance will be poor. The patient may not follow the instructions given by the doctor. So all these factors interferes with the treatment, which contribute to death or disability in the patient. So what are the DSM-5 criteria? So A is a medical symptom or condition is present. It means the person is already diagnosed with some medical problems, medical illness. B, the psychological or behavioral factors adversely affect the medical condition in one of the following ways. First, the factors have influenced the course of the medical condition as shown by a close temporal association between the psychological factors and the developmental or exacerbation of or delayed recovery from the medical condition. So anything can happen. But if there is a temporal association, means the illness and the psychological factors are related. So the factors interfere with the treatment of the medical condition. The factors constitute additional well-established health risk for the individuals. The factors influence the underlying pathophysiology, precipitating or exacerbating symptoms or necessitating medical attention. So what happens if you see the 4.4? These factors may again worse the illness. So for example, if the patient is having diabetes mellitus and he is having psychological factors, depression and certain other things, anxiety. So the person thinks, what is the point of living now? I have developed sugar, diabetes, so I may lose my eyesight, my kidney will be after some time. So what is the point of living? I can't live with such type of problem, so I should die. So all such type of things may exacerbate or create more problem for management of anxiety and worsening the sugar level. The psychological and behavioral factors in criterion B are not better explained by any other mental disorders. So all these factors 1 to 4 cannot be explained on the basis of depression, anxiety, generalized anxiety disorder, or major depressive disorders. So let us see the treatment. So approaches include education about the illnesses and the risk of not treating it properly, and teaching individuals about the effect of psychological factors or behaviors on their health. Psychotherapy such as CBT and motivational interviewing may also be helpful. Coming to factitious disorders. You might have heard about this disorder. So, factitious disorders, individuals voluntarily produces the symptoms of any medical disease. The essential features like falsification of medical or psychological signs or symptoms in the absence of obvious external rewards like financial gain or time of work. It means the person is not complaining about those symptoms on the basis of any reward or any gain, but the person explains those symptoms. There may be no obvious reasons for voluntarily producing the symptoms in oneself, except in some cases it may be done to assume the sick role and receive increased attention. So the person may not have any physical basis, but the person say that he is having certain problem and it requires urgent treatment. For instance, let us like this is not a illness and anxiety disorder. This is not somatic symptom disorder. So see, this example very clear. What is factitious disorder? A woman introduces alkaline chemicals into her eyes, causing corneal burns before visiting an ophthalmologist. Why she has done? There is nothing can be explained कि she will get benefit or she will this or that. No, this is just the person in those symptoms. In another case, a man goes to the hospital complaining of abdominal pains, demanding a surgery for removal of his appendix. Upon being refused, he goes to another hospital with self-induced abscesses in his stomach with a kitchen knife. Understood? So that's why this is factitious disorder is different from illness anxiety disorder and somatic symptom disorder. This disorder may extend to other members of the family. An adult may purposely make her child sick in order to receive attention and pity given to her as a mother of a sick child. So, diagnostic criteria, four primary criteria for diagnosing factitious disorders: intentional induction or falsification of physical or psychological sign or symptoms. The individual presents themselves as ill, impaired, or injured to others. The deceptive behavior persists even in the absence of external incentives or reward. They may not get benefited with such behavior, even though they fail. Another mental disorders does not explain this behavior, then we can diagnose. So, what is the treatment? There is no known single treatment for factitious disorders. Treating issues around the factitious disorder, such as any comorbid conditions, often brings an end to the factitious disorder itself or enables management of the condition. So, treating potential underlying causes such as historical childhood traumas may produce similar results. CBT may be used as a treatment method, and family therapy may also be suggested to help those around the individual understand and manage the disorders. And medication may be used to treat symptoms of co-occurring psychiatric disorders or any other medical disorders. So let us see how we can distinguish between conversion disorders, factitious disorders, and malingering. So there in conversion disorders, there is no motivation of faking symptoms. Anxiety is responsible for occurrence of medical symptoms. Freud observed very little fear or anxiety that would be expected in a person with paralyzed arm or loss of sight. Even though the person had paralysis in conversion disorder, the person will be having less anxiety, not very much concern. However, later on, lack of concern, like it was called la belle indifference, was considered as hallmark of conversion reactions and included previous DSM versions, but finally removed from DSM-4. Only 30 to 50% of people with conversion symptoms showed this lack of concern. It means around 50 to 70% patients, they show concern about their symptoms. But this concern is not very in depth. They just show concern, they just ask. So they are not very much preoccupied with their symptoms. The role of psychological factors was considered an important criterion. Emotional interpersonal conflict or stressors commonly precede conversion symptoms. Occurrence of stressful life situations was removed from DSM-5. So it may not, the conversion disorder may not precipitate after any stressful life situations. Without any stressful life situation, also it may be there. But this stressful life situation may be there in the past. So presence of a psychological stressor is a hallmark. So it means psychological stressor must be there. It may not be there immediately before the symptoms occur, but it must be there. People with conversion disorder may function normally. So if you exclude the episode of conversion disorder, otherwise they are functioning normally. They are doing their job. They are doing their household chores. Everything they are doing, but during the time of conversion disorder, which may last for 5-10 minutes to 2 hours, 5 hours, otherwise they are all right. Infectious disorder, this disorder lies somewhere between malingering and conversion disorders. Symptoms are under voluntary control. So in all other disorders we have read, like somatic symptom disorder, illness anxiety disorders, conversion disorders, in all other disorders, the patients cannot control their symptoms. Their symptoms are not under their control. But in infectious disorders, this is the core quality which differentiates it from all other disorders. The symptoms are under voluntary control of the patients who are suffering from infectious disorder. So there is no obvious reasons for voluntarily producing the symptoms, as we have discussed. So there is no reason. You may not find any stressor, you may not find any gain, you may not find any incentive. So why the person is behaving in such a manner, why the person is taking a sick role. So this is not associated with infectious disorder. So no one can say that why the person is behaving like this because he will be getting benefit. No. Let us see the malingering disorder. So this is basically faking psychological symptoms. So this faking is generally seen in legal cases, prisoners. Okay, they want to get some benefit on the basis of their psychiatric. They show that they are having some psychiatric disorders, so they fake the psychiatric symptoms. So that is called malingering. So they have clear motivations such as trying to get out of a legal or work difficulties or financial benefits. Okay, so if you do not want to go to college or school, you may feel that there is a pain in your abdomen. So you can say, I have a pain, I want to go to school, college. And if you are working, you may say that you know that today is lots of work you have to do. So you may get, you say that you are having headache or fever or body ache, you can't go and work. Even though you have gone to work, there you say you are not feeling well, you are feeling nauseated, you are feeling headache, so you want to go back home. So these are the malignant. So they are fully aware of what they are doing and are clearly trying to manipulate others to gain something desirable. So, so the motives are clearly understandable by others, and the patient is well aware why patient is behaving such a way. Like patient may not behave, the patient in jail, the patient may behave like he is hallucinating, or he knows about the religion, so he may uh, tell others that others are trying to kill him, or he may show panic symptoms, but he is aware that he is doing all these things purposely. He is well aware. Yeah, so it's not like that he is not aware. He is well aware. Okay, so let us summarize today's presentation. So we have discussed about the various somatoform disorders, and these disorders are somatic symptom disorders. Then, uh, then we have illness anxiety disorders. Then we have conversion disorders. We have discussed about the factitious disorders, and in the last we have discussed about the malingering. So basically, malingering is not a disorders because the person is well aware, but it creates problem for the health professionals, for the psychiatrists, for the psychologists, that they cannot, because they have to diagnose. If someone is complaining, they have to diagnose. So the diagnosis should not be false. So for that, they must be aware about the intention of faking such symptoms. Okay, so in uh, conversion conversion disorders, we have seen that it will be explained on the basis of psychoanalytical. So there may not be any genetic basis, there may not be any other biological factors playing a role. They are not well established research till now on this basis, but there is a unconscious things going on, and the desires which the aid wants to fulfill is basically creating problem for the ego. So ego convert this disorder, this anxiety into physical symptoms. So the physical symptoms will look like neurological disorders like epilepsy. So we have differentiated epilepsy is a neurological disorder, whereas pseudo seizure is conversion disorders. So we are not talking about epilepsy, and the psychologist cannot diagnose epilepsy. Epilepsy is diagnosed by neurologist, okay, or any medical person who is expert in brain study. So there are different things. EEG can be done, MRI, CT scan. On those basis, it can be diagnosed. We have also seen the difference between somatic symptom disorder and illness anxiety disorders. And we have also seen the difference between factitious disorder and malingering. Okay. In factitious disorders, also patient purposely does some things, but there is no gain. Whereas in malingering, the person is having hidden gain. If the person, suppose if the person is in jail and diagnosed with psychotic disorders, so he may get bail, or he may not be fit for stand trial. So court will say, okay, he is not fit, so first get his treat him. Then if he becomes all right, then only we can proceed. So these are the things. We so this was a very interesting topic today we had discussed. In next class, we are going to discuss about the personality disorder. So personality disorder is basically diagnosed after the 18 years of age of the patient. because before that we think that the personality is still growing stage, so we cannot say that confidently this is the personality problem in this child. So in personality disorder, we first see different types of personality disorder because they are very highly prevalent in our society. And these disorders are basically like antisocial personality disorders, borderline personality disorder, histrionic personality disorder, narcissistic personality disorders. So all these personality disorders we are going to discuss in our next class, and we'll see these personality disorders like how they create problem for a person or for his family. So if the person is aware about the personality disorders, uh, so then he may work on this issue. But becoming aware is a most difficult thing, and it is a difficult job for the psychologist to make the person aware that he is having some problem. So there are different modes of interventions, therapies going on for this management of the personality disorders. Under that, one very highly used therapy is dialectical behavior therapy. Dialectical behavior DBT it is called. It is basically used in borderline personality disorders. So in borderline personality disorders, basically the emotional instability is seen, self-harm is seen, so lots of symptoms seen. So you must be very clear about the personality disorder symptoms and personality disorders person. So in many people, you may find some types of personality symptoms like cluster A, cluster B, cluster C symptoms. So symptoms may be present, but if they become the illness, so if they become the diagnosable illness, then it is difficult for the person, it is difficult for the family member, it is difficult for the others to manage the person. For example, antisocial personality disorder, the person used to tell lie, the person exploits other, the person uh, does lots of antisocial activity, the person may not show respect or regard for the society. So we'll see in our next class, next Friday, we'll see personality disorder. Thank you. Namaskar.